You know that sudden cold drop in your stomach when your fingers brush against something that just shouldn't be there?
Oh yeah, definitely.
Right, like you're just washing your face or adjusting your collar, and suddenly you feel it, a lump.
In your neck.
Exactly, right there in your neck. I mean, for most of us, the mind it instantly races to the absolute worst case scenario, you know?
It is a terrifying moment.
It really is. It's like this universal human experience to feel that bump and just, well, panic.
And that panic is completely understandable. I mean, the neck is packed with vital structures. You've got major airways, critical blood vessels feeding the brain, nerve bundles.
It's crowded in there.
Very crowded. It's an incredibly high-rent district of the human body, so any new arrival feels, incredibly threatening to you.
Totally. So today, for this deep dive, we're pulling back the curtain on exactly what happens next when you take that lump to a specialist.
Right, we've been reviewing a fascinating stack of medical literature and surgical decision-making guides.
Specifically looking at how top surgeons decode these mysteries of the head and neck. Because our mission today is to show you the exact mental algorithms, the real-time detective work that doctors use.
Because it turns out the process is so much more than just see a lump, cut it out.
Yeah, far more complex, right?
Exactly. The diagnostic landscape we're exploring today requires a doctor to act as an anatomist, a chemist, and even a geneticist.
Often before they ever consider picking up a scalpel.
Right.
So let's unpack this. We have to start by setting the stage with one of the most hidden, complex neighborhoods in the entire human body.
The parapharyngeal space.
Yes, the parapharyngeal space. And well, what blew my mind right away is that masses in this area often present as totally asymptomatic bulges.
Yes, completely silent.
Right, like you might just go in for a routine dental exam or physical, and the doctor notices a bulge in the back of your throat or your palate, but you feel totally fine.
The reason for that silence is just the sheer amount of empty space and fatty tissue in that specific region.
Ah, so it has room to grow.
Exactly. It's basically a vertical tube of fat and connective tissue running alongside your pharynx. So a tumor can grow there for quite a while, simply pushing soft fat out of the way.
Without compressing anything that causes pain.
Right. But the clinical algorithms outline very specific red flags that immediately elevate the suspicion of malignancy.
Like what? I mean, what turns a silent bulge into a glaring siren?
Well, if a patient comes in with a lump accompanied by severe pain or something called trismus, that changes everything.
Trismus?
It's lockjaw, basically. The inability to open the mouth fully. That changes the entire trajectory of the investigation. Another major red flag is vocal cord paralysis.
Which presents a severe hoarseness, I assume.
Yes, exactly.
I would guess that means the tumor is no longer just pushing fat around, but actually like invading the nerves that control
the jaw or the vocal cords. Yes, exactly. That is the crucial distinction. When a doctor feels the mass and notices that it is fixed in place rather than mobile, it suggests the tumor has anchored itself.
By invading surrounding tissue or bone.
Right? Or blood vessels. And that triggers a highly advanced structural mapping process. The doctor has to navigate a space they can barely see from the outside.
Which requires advanced imaging, right? Like CT scans with contrast or MRIs.
Exactly.
But how they actually read those scans is wild to me. The literature divides the area into these microregions, like the prestyloid, poststyloid, and retropharyngeal spaces.
It sounds complex, but it's very systematic.
But they aren't just looking at the dark blob of the tumor itself to figure out what kind of cells it's made of, right? They actually figure out what the tumor is by looking at what is pushing out of the way.
Anatomy is truly destiny in this part of the body. The structural displacement provides the very first vital clue.
It's like trying to figure out if an invisible intruder in your house is a burglar or a bear just by looking at which furniture got knocked over.
That's a great way to think about it.
Right, because if the TV and the couch are pushed quietly to one side of the room, it's a burglar. If the refrigerator is tipped completely over and the door's ripped off, it's a bear.
What's fascinating here is how accurate that analogy is to the surgical algorithm. This spatial mapping dictates the very first major decision.
Really? How so?
Well, for instance, if a mass originates in the prestyloid space, which is usually a minor salivary gland tumor, it will displace that hidden parapharyngeal fat in a very specific direction.
Okay, so where does it push it?
It pushes the fat anteromedially, meaning forward and toward the center of the throat.
Okay, so that's the burglar sneaking around the couch. What about the bear?
Right, so if the imaging shows the fat and the major blood vessels being displaced straight anteriorly, just shoved directly forward, that indicates a mass in the poststyloid space.
And those are different types of tumors?
Yes, those are usually nerve sheath tumors or something highly complex called paraganglioma. So without taking a single biopsy, just by seeing which way the invisible fat was shoved on the MRI, the surgeon has already narrowed down the cellular identity of the tumor.
Which leads me to my next question and one of the biggest surprises in the sources.
The do not touch rule.
Exactly. Because once you know where the tumor is, my logical assumption as a patient is that the doctor's very first step is to just stick a needle in it and test the cells.
That is what most people assume.
Right, but the algorithm puts up a massive flashing stop sign before anyone is allowed to do a fine needle aspiration or FNA.
A needle biopsy is strictly forbidden until one major question is answered. Is this mass highly vascular?
Because if it is, that's a huge problem, right?
It is. If you blindly insert a needle into a tumor that is essentially a tangled ball of high-pressure blood vessels, you can cause a catastrophic hemorrhage right there in the clinic.
Then how do they know if it's a blood vessel tumor without looking inside it?
They listen and they feel. Doctors check for clinical signs known as brutes and thrills.
Brutes and thrills? That sounds like a 1950s jazz band.
It does, doesn't it? But a brute is the distinct sound of turbulent blood flow that the physician can hear through a stethoscope placed on the neck.
Oh, okay. And a thrill.
A thrill is a physical vibration you can actually feel with your hand over the skin. It vibrates almost like a purring cat. If either is present, it indicates massive vascular pathology.
Wow. The most dramatic example of this in the literature is the paraganglioma, specifically a carotid body tumor.
Those are incredibly challenging.
The imaging for these is terrifying. They don't just sit next to your blood vessels, they literally splay apart the internal and external carotid arteries.
Yes, they wedge themselves right into the primary fork of the arteries feeding your brain.
That is wild.
And their complexity goes far beyond their location. Paragangliomas have a high multicentricity.
Meaning they often don't appear alone, right?
Exactly. Synchronous tumors, having more than one tumor at the exact same time, are found in about 10% of patients. Furthermore, there's a strong genetic link.
A familial tendency.
Yes, in up to 25% of these cases.
The bleeding risk definitely makes sense, but the sources detail another danger inside these specific tumors that sounds like, I don't know, a biological booby trap, something about catecholamines.
Catecholamines are hormones, primarily adrenaline and noradrenaline. Some paragangliomas actively secrete these hormones into the bloodstream.
Wait, I thought adrenaline came from the adrenal glands, which are way down above the kidneys. Why would a random tumor in the neck be packed with adrenaline?
To understand that, we have to look all the way back to fetal development. These tumors grow from neural crest cells.
Okay, so what do those cells normally do?
Well, when you are a developing embryo, these highly specialized cells migrate throughout the body to help form the nervous system.
Which includes the neuroendocrine system responsible for the fight or flight response.
Precisely. Sometimes clusters of these cells remain in the neck. If they form a tumor, they can retain that original biological programming to manufacture and dump adrenaline.
So if a doctor just jabs a needle into that tumor or like starts cutting it out without knowing what it is?
It triggers a massive uncontrolled flood of adrenaline directly into the patient's system.
Oh my God.
Yes. The sudden release of catecholamines will cause blood pressure and heart rate to skyrocket to lethal levels instantly.
So as a patient, you come in terrified, wanting answers immediately. You just want the biopsy to know if it's cancer. It is deeply counterintuitive to hear a doctor say, we have to wait.
But that wait is life-saving. The clinical pathway requires that vascularity and chemical secretion be fully excluded via imaging and lab tests before any needle is introduced.
And if it is a secreting tumor,
Then the surgeon cannot proceed without a specialized anesthesia consultation. the patient requires preoperative adrenergic blockade with medications like propranolol or phenoxybenzamine.
They essentially have to chemically block the body's adrenaline receptors in advance.
Exactly. So when the tumor is removed and releases that adrenaline storm, the patient's heart simply ignores it.
Wow, precisely matching the surgical preparation to the biological threat.
And even the physical approach to the surgery is highly calculated based on these factors.
Right, like for a benign non-vascular tumor, they might use a transcervical approach, making an incision in the neck.
Or they might employ TORS, transoral robotic surgery, going in through the mouth with a robotic arm to avoid visible neck scars.
But a surgeon would never use a robotic mouth approach for a highly vascular paraganglioma.
Never. The risk of uncontrollable bleeding requires wide open access to the major vessels.
Well, here's where it gets really interesting. We've been exploring these incredibly rare, hidden structural tumors.
That's right, the zebras of the medical world.
Exactly. But the source material shifts focus to the absolute most common neck lump that people encounter, the thyroid nodule.
Yes, thyroid issues are incredibly common.
And when we look at the thyroid, the mental algorithm the doctor uses completely transforms. It stops being purely about physical geography and becomes a dual-track investigation.
Investigating both structure and chemical function. Thyroid enlargement, commonly known as a goiter, is a frequent clinical presentation.
Unlike the parapharyngeal masses, where the primary goal is just identifying and removing a physical obstruction.
Right, the thyroid algorithm demands two simultaneous goals: ruling out malignancy and correcting systemic hormonal dysfunction.
To understand how wild the symptoms of a broken thyroid can be, let's look at a modern analogy. Think of your body as a massive smart home, and the thyroid is the central climate control thermostat.
I like that analogy.
It controls the metabolic temperature of every room in the house. Your brain communicates with this thermostat using a Wi-Fi signal called TSH, or thyroid stimulating hormone.
If we connect this to the bigger picture, the symptoms of hypothyroidism are what happen when the furnace is completely broken.
The metabolic fire just goes out.
Exactly. You experience profound fatigue, dry skin, unexplained weight gain, and severe constipation.
And because the house is freezing, the brain starts screaming at the thermostat. It cranks the Wi-Fi signal to maximum.
Right, so when the doctor checks your blood, your TSH levels are sky high, desperately trying to get a broken furnace to turn on.
Which is just fascinating. And the most common cause of that broken furnace is Hashimoto's thyroiditis. Right?
Yes, it's a chronic autoimmune disease where the body's own immune system mistakenly attacks and slowly destroys the thyroid gland.
So because the physical machinery is damaged, surgery is rarely the answer.
Correct. The treatment is replacing the missing hormone systemically with a daily medication called levothyroxine.
But then there's the polar opposite problem, hyperthyroidism. The thermostat is glitched, and the furnace is stuck on maximum heat.
Your body is essentially redlined.
Right, you have a racing heart, rapid weight loss, heat intolerance, tremors.
In this state, the brain realizes the house is burning up, so it completely cuts the Wi-Fi signal. It stops sending TSH.
So your blood work will show almost zero TSH, but the thyroid continues churning out hormones anyway.
Exactly. And the prime culprit for this is Graves' disease, which causes a diffuse goiter and often features a condition called infiltrative ophthalmopathy.
That's where the tissues behind the eyes swell and cause the eyes to visibly bulge, right?
Yes, it is.
Now, the diagnostic tool used to figure out exactly how the thyroid is malfunctioning sounds like pure science fiction. It's called radionuclide scanning, or scintigraphy.
It is a brilliant piece of diagnostic technology.
They basically give you a radioactive pill, and they literally watch your neck eat it.
That's a colorful way to put it, accurate. The thyroid gland has an insatiable biological hunger for iodine. It uses it as the raw material to build its hormones.
So by introducing a safe radioactive iodine isotope, doctors can visually track the chemical factory at work.
Right. If the scan shows the entire gland uniformly glowing, absorbing massive amounts of iodine, it reliably confirms Graves' disease.
But what if it isn't uniform? The literature mentions something called toxic multinodular goiter.
Yes. If the scan reveals a heterogeneous gland, meaning spotty, localized hotspots of high radioactive uptake, surrounded by dark, inactive tissue.
That points to the toxic multinodular goiter.
Exactly, which is actually the primary cause of hypothyroidism in older adults.
And because the thyroid is a dynamic chemical engine, treating these overactive states requires systemic interventions first, right?
Yes, things like antithyroid medications, beta blockers to slow the heart rate, or targeted radioactive iodine to selectively destroy the overactive nodes.
With total surgical removal usually reserved for when medical management fails, or if the goiter grows so large it physically crushes the airway.
Exactly right.
Okay, so that covers the scenarios where the chemical factory is malfunctioning. But a huge portion of the sources is dedicated to a totally different puzzle.
The incidental findings.
Right. What happens when your thyroid's chemical function is completely normal, but there's a physical nodule sitting right on it? This brings us to a massive modern medical phenomenon that doctors call the incidentaloma.
An incidental finding, exactly. A patient undergoes an imaging scan for an entirely unrelated reason.
Like maybe they suffered whiplash in a car accident, or they need an MRI for a cervical spine nerve issue.
Right, and during that scan, the radiologist happens to spot a tiny asymptomatic nodule on the thyroid.
And the statistics on this are staggering. I mean, the incidence of diagnosed thyroid cancer has tripled since 1975. Tripled.
It's a dramatic increase.
When you hear that, you assume there is some new toxic pathogen in our environment. But the medical consensus attributes this massive spike entirely to the increased resolution of modern ultrasound technology finding these tiny hidden incidentallomas.
The critical context required here is the survival rate. Well-differentiated thyroid cancer represents over 90% of these new malignancies.
And the survival rate is really high.
Very high. It boasts a greater than 80% 20-year survival rate. To put that in perspective, while it accounts for nearly 4% of all new cancer diagnoses, it causes only 0.3% of cancer deaths.
Which forces a very uncomfortable question. I mean, if the cancer diagnosis rate has tripled, why haven't the death rate spiked right alongside
That's a
that?
valid question.
It strongly suggests that our advanced technology is finding microscopic cancers that might have just sat quietly in the neck for the rest of a person's life without ever spreading or causing harm.
That paradox places a heavy burden on the clinician. They must carefully risk stratify these nodules to avoid performing unnecessary life-altering neck surgeries on the 95% of nodules that are perfectly benign.
And to filter the noise, they rely on the AMES criteria.
Yes, AME stands for age, metastasis, extent of disease, and size.
So the patient's demographics significantly alter the risk profile. High risk typically includes females older than 51, males older than 41, children, and any nodule larger than 5 centimeters.
Exactly. And beyond the patient's age, the ultrasound provides crucial visual clues about the nodule's architecture.
So they aren't just measuring how big it is, they are analyzing the shape and the internal texture.
Right. A high-risk nodule on an ultrasound displays very specific suspicious features. It often appears hypoechoic.
Meaning the tissue is denser and reflects fewer sound waves, making it look darker than the healthy thyroid tissue around it.
Yes. It might also be described as taller than wide, meaning it is growing against the natural tissue planes rather than spreading out parallel to them.
Or it might contain microcalcifications, those tiny flecks of calcium that often accompany rapidly dividing cancer cells.
Precisely.
There's also this fascinating paradox regarding those radioactive iodine scans we talked about earlier. They classify nodules as either hot or cold based on how much iodine they absorb.
Yes, and this is where it gets interesting.
Right, because you would naturally assume a hot, hyperactive, aggressively functioning nodule is the dangerous, cancerous one.
But it is a brilliant example of how cellular biology informs the diagnosis. Functioning hot nodules only carry a 4 to 5% risk of malignancy.
Wow, so it's a cold, non-functioning dead zones on the scan that demand immediate attention.
Yes, carrying a roughly 15% risk of being cancer.
But why is a dead zone more dangerous than a hyperactive one?
Because cancer cells are heavily mutated. As they mutate to prioritize rapid, uncontrolled division, they lose their original biological programming.
So they forget how to do their normal job.
Exactly, which in the thyroid's case is absorbing iodine. So a cluster of of mutated cancer cells will appear completely dark or cold on an iodine scan.
That makes so much sense. Now, if the doctor spots a cold nodule with suspicious ultrasound features, the algorithm dictates moving to a fine needle aspiration, or FNA, to get a tissue sample.
Yes, a biopsy.
But the sources dedicate a lot of ink to what happens when that standard needle biopsy fails to give you a straight yes or no answer.
The FNA is an imperfect tool. There is a significant risk of sampling error.
Like, if the lesion is massive, say over 4 centimeters, the needle might easily plunge into the healthy tissue surrounding the tumor, missing the cancer entirely.
Or conversely, if the nodule is less than 1 centimeter, it becomes an incredibly difficult target to accurately hit.
And even when the surgeon gets a perfect sample, the pathologist looking through the microscope might not be able to tell if the cells are benign or malignant.
Which is why, to manage this ambiguity, the medical community created the Bethesda classification system.
The Bethesda classification, that's the standardized language of cytology for thyroid nodules, right?
Yes, it allows doctors globally to communicate risk with uniformity.
So, for example, if a biopsy is rated as Bethesda class 4, the patient has a 15 to 30% chance of malignancy.
Correct. A class 6 rating, however, represents a 97% certainty of cancer.
It's those middle indeterminate categories of class 3 and 4 that must drive patients and doctors crazy.
Yeah.
You did the scan, you did the painful needle biopsy, and the answer is still maybe.
It is incredibly frustrating. But this is where the source material introduces an absolute game changer: molecular testing.
Right, when the microscope reaches the limits of human sight, we turn to the DNA. The texts detail 2 specific molecular panels. One is called ThyroSec, which analyzes 14 specific carcinogenic point mutations and gene fusions.
And its primary strength is definitively ruling in cancer. If those specific mutations are present, surgery is required.
Then there's the Afirma panel, which is highly sensitive and analyzes a massive sequence of 167 different genetic loci.
Yes, and its strength is safely ruling out cancer.
Which is huge. The clinical utility of molecular testing cannot be overstated.
By analyzing the genetic signature of the cells, doctors can confidently tell an anxious patient, your DNA shows this is benign. You do not need your thyroid removed.
Or conversely, your genetic markers indicate an aggressive mutation. We need to schedule a total thyroidectomy immediately.
Exactly.
So what does this all mean? To me, it perfectly illustrates how hyper-personalized medicine has become.
It really has.
Decades ago, the question was simply, do you have a lump? Then it evolved to, do you have cancer cells? And now the question is, what exact 14 gene mutation does this single microscopic cluster of cells possess?
This raises an important question, though, one the medical literature addresses quite soberly. The clinical algorithm eventually encounters the grim edge cases where all this high-tech genetic science collides directly with profound human reality.
You're referring to the highly aggressive variants like anaplastic and medullary thyroid carcinomas.
Yes, anaplastic thyroid carcinoma is one of the most aggressive and lethal solid tumors known to medicine.
That's terrifying.
When that diagnosis is confirmed, the entire medical algorithm shifts instantly. The primary goal completely abandons curative surgery.
So what do they do?
The immediate focus becomes securing the patient's airway, which often involves discussing a tracheostomy to help him breathe, placing feeding tubes, and urgent consultations with oncology.
The most critical and difficult step outlined here is the rapid establishment of end-of-life care goals.
It is.
It's a stark reminder that behind all these complex flowcharts, molecular panels, and survival percentages is a human life facing a devastating reality.
It truly is. And the medullary thyroid carcinoma edge case carries a completely different, but equally heavy weight.
Right, because medullary carcinoma originates from specialized cells in the thyroid that secrete a hormone called calcitonin.
Yes, and because of its unique pathology, it requires systemic calcitonin testing. But more importantly, it requires immediate genetic screening of the RET proto-oncogene.
Which means if a patient is diagnosed with this specific cancer, the doctor has to look at the patient's children and blood relatives.
Exactly. The algorithm dictates screening the entire family to see if they carry the same mutation.
Which might require healthy children to undergo prophylactic thyroidectomies to prevent them from developing the cancer later in life.
The responsibility is immense. The doctor is no longer just treating the isolated lump in the patient's neck. They are actively navigating and intervening in the future health of an entire family tree based on a single molecular test.
Wow. Well, to recap the journey we've been on today, the next time a doctor feels your neck during a physical, realize they aren't just checking a box.
No, they're running a massive high-speed decision tree.
Exactly. They are looking at how hidden fat is displaced to see if the intruder is a burglar or a bear. They are listening for turbulent brutes to dodge the biological tripwires of adrenaline-secreting tumors.
They are checking the body's smart thermostat to balance your metabolic engine.
And finally, they're utilizing 167 loci genetic tests to spare you from unnecessary surgery.
And that intricate mental algorithm is constantly updating in real time as every single new piece of evidence comes to light.
Whether it's the physical exam, the ultrasound texture, or the molecular DNA test, it's detective work operating at the highest possible level of science.
Truly.
Which leaves you with one final thought to mull over. We learned today that the massive tripling of thyroid cancer diagnoses over the last 50 years was driven entirely by better ultrasound technology, finding tiny asymptomatic anomalies.
Yes, the incidentallomas.
But imaging technology is only accelerating. We are rapidly moving toward a world of whole body MRIs and AI-driven scans that will soon be able to map every single cell in our bodies in real time.
The level of precision is approaching the absolute.
So, as our ability to see inside ourselves becomes infinitely more powerful, are we approaching a future where the concept of a normal body ceases to exist?
That's a profound question.
Right. When an AI can point out every microscopic anomaly, mutated cell, and structural flaw you possess, will the hardest medical decision a doctor has to make be figuring out what not to treat?
It completely redefines medicine.
It makes you wonder. The next time you feel a sudden panic over a random lump, maybe the scariest thing isn't what the doctor will find. It's that soon they might be able to find absolutely everything.